wonderful if you're integrated as a payer or as Kaiser. We even, acquired by a hospital system, aren't entirely aligned as a medical group. So that's a real conundrum. Taking patients out of the hospital is not the best thing for a $1 billion hospital that's going on. So it's quite a dilemma, I guess.
Misaligned incentives, technology, data, and anything else we want to bring up for that group? Okay, let's go to the second group. All right, first of all, any questions for that group? Let's do group number 2.
Sure, I'll speak up. Well, as Steve mentioned, he very graciously hosted us up in Seattle, and so we were very interested, at Lisa Sharpie-Staley, about what they were doing. What we're interested as far as in adopting, I mean, we're using it as kind of a platform for redesigning practice and have a pilot going on. And we're looking at things like how to provide the clinician, the team, the information they need at the time the patient's there, not after the fact or at some other time. More use of emailing, more use of Teams. Barriers, we're fortunate, almost 2/3 of our patients are managed care, so we don't have the financial barriers that a lot of people would have to do this. We don't lose money by being efficient, but for our PPO patients, we do. And if I start handling their concerns over email or being more efficient with them, that hurts our bottom line. Now, maybe ACOs will help that. We're hoping. Drivers of how the patient will have better blood pressure and lipids and A1Cs and that. I mean, motivated patients is probably one of the key. If the patient's motivated, they'll come back, they'll work with you and probably help to get this done. The patient needs to have the ability, though, to actually get the prescription and have the funds to have it monitored, and that's something that if they can't do it, it doesn't matter how motivated they are. We were talking about possibly a new approach, maybe give them a poly pill type thing and monitor it once with some of the funds we save from ambulances and hospitals, and just wish them luck and say, keep taking your poly pills for the rest of the decade or something.
Any other comments from that group?
Well, it seemed like when Steve mentioned what they've done is redesign their system so that they have easy communication with the patient, and building on that, then if there is a deficit, you actually have to focus exactly on the thing that you want. If you want it on a lipid net, you got to focus on it. But that could be done very easily, and what we figured out was inside the systems that have electronic medical records, it's still not easy, but a single click that will send the prescription and document what you did, so that the physician has it. The easiest thing to do is look at this. They have a red flag. You see the red flag, make the one click, and everything happens for you. And I think that putting these three things, these ideas that Sharp and Steve brought together, is really brilliant. I think it'll work. All right, it's worth a try.
Any questions for that group? Now let's go to the third group. Who's your spokesperson? Any volunteers? I see everyone looking at Ray.
And so, well, as we heard from the group, at Kaiser we have the electronic medical record. So we have adopted the patient-centered model. And so working on that, one thing that I brought up with the group with Tony before he had to leave is he was saying as a cardiologist, he gets all of these messages about the wife's Fosamax or this non-cardiology related question. And I said, oh, that wouldn't happen at Kaiser, would it, Jim? We would have a pool, and the call center would have said to the patient on the line that, no, this is a question or concern for your endocrinologist, if it's that, or a primary care doctor. And so just having a pool within the electronic medical record so that the doctor's not the first one to see the messages, that it's the pool and this back office staff. And then on that note, it's working with your back office staff. They're key in this, like I was saying, the answer to number 3 is actually the back office staff, and having them work to their fullest potential, meaning their highest scope of practice within the service rep, the MA, the LVN, the RN. And so we all know there are various 1 and 2s of each of those. But if a patient was to send in an email or to call saying, I need to schedule my pap smear, I don't need to see that. schedule that. It goes to the service rep, or the patient has a question and wants their lab results. Well, if they're normal, I don't need to see that either, the back office staff. If they're abnormal, I need to adjust something, then I do need to see it. But it's really, the messages come to me when we need some type of advice or, higher level of training or the medication adjustment. So I think this is a great training, but that's Kaiser. For those that don't have that already EMR and everything in line and the years to get it to this point at Kaiser, it's a little more difficult. There are a lot of barriers in the community, and I don't know if you wanted to comment on, either of you wanted to comment on that. but-
Some of them are, of course, the money that it costs, and the other is just, learning, teaching and training your support staff on how to do those, and having and developing policies and procedures that guide them, guidelines, and this is what you do, and this is what happens there. So there's a big, all of us in our group recognize the merit, and all of us understand this is good. But yet, we're all talking about implementing it, but we haven't done it, other than maybe Kaiser.
Right, it's the
Those
big
rest of us are kind of planning.
And I want to just mention one other barrier, which is cultural.
Yes.
I think all of us were trained in a reactive mode in medicine. I know in my residency training, you rushed into the ER, you took care of whatever was in there, that was your training. And I often tell my doctors what we're moving to is really a reactive medicine to be proactive type of medicine. And that's a real cultural shift, I think, for physicians and even staff and throughout the organizations. That's just not how we were ingrained. So on that note, make sure to fill out your evaluations if you have, especially if you have topics that you want to get covered in the future. We are always looking for good topics.
Can I just ask a quick question for Dr. Tarrnoff and also Kaiser? So with the email access where patients can email in, where do those go? Do those go to an MA, or the physician directly, and does someone triage those?
Yes, so for us at Kaiser, the way that we have most of them set up is to go to the RN in case it's the hypoglycemia, something like that, because unfortunately some patients email that in. The RN then has to call that patient, so it won't go to the service rep, the MA, or the LV, the RN would
So
have
it
to
goes to
call.
the PODS RN inbox?
You got it, so I don't see them first. They
So
see
everything
them.
essentially would go through an RN.
Yes, sometimes, though, we do have pharmacists, obviously, we have pharmacists, and so they might send a message saying the patient called in for this prescription refill, so the pharmacist can send it to us directly. Home health, so some people have direct access within Kaiser to send us messages, but as far as the members, it goes
You
to
have
that.
an RN triage. How about,
Those exact same thing, we don't, we have somebody on the team who triages it, and if they can answer it or someone else, like